Okay, so record.
Hey, Kara, will you upload, can you upload these recordings to SharePoint?
Yeah, no, that's why it should be on the implementation guide.
Oh, okay, perfect.
Yeah, takes me a minute to get it up there because it takes it a while to do whatever it's doing, downloading, but the last week should be out there. And I guess you would have access, but no one else.
Perfect, thank you.
You're welcome. Let's see, okay. I just was gonna kind of give you a heads up again. Today, we're gonna go over access control. That's, where the clinic goes and looks at the results of the screening. A quick, two-liner about setting up the tablets, because I know you guys already know that. And then I'm gonna head over to RedCap and show you how to set up a clinic in RedCap, and then how to, document your visit, just so you can familiarize with what it looks like. And then the Departmental Health has put together a slide deck. I did hit record, didn't I? Yeah, okay, sorry.
Yeah, you did.
A slide deck, and it's just a big informational SBIRT everything to share with your clinic in sections as you feel needed. So access control, here's the link to it. This is what it looks like when you log in. It's really simple to get logged in. To get our access, you have to fill out a form like this, and that link was on that page before here. You'll email Lori, and her contact information is on here, but once you fill this out, agree, submit, she does her thing, and then lets you know that you have access. Once you have access, it looks like this. You probably won't have as many icons here, but this was the one, and I think I can't see it, but maybe this one. Click on it, and then this is what it looks like when you click on it. And for
Kara,
yeah.
I'm sorry to bother you. So if you
No.
go back one slide, since this portal right here, I already have access to it because that's how Lori gives me the data. So I guess I'll just, once I fill out that form, I'll just see that SBIRT adult icon there. Is that right?
For you, just email Lori and tell her you need access to adult SBIRT.
Got it. Got it.
It'll just magically appear up there.
Okay, perfect.
Okay. And then you'll just have access to your clinics. You won't be able to see Jimmy's or Allie's or, Tina's or Jennifer's. But you'll look on here, you'll see the scores for the screens, and then the flag is the if they've screened positive for suicidality. You have a question, Jimmy, or you good?
No, did I have my hand up or something?
Oh, well, no, it clicked off and I just caught it. So you know how sometimes.
Oh, sorry. No.
You're good. And then for the clinic, you can view it on this screen or click the report. You can print the report to the printer, save it as a PDF, send it to the EMR, or the clinic can open it up on their desktop, save it as a PDF on their desktop. But you heard that whole spiel yesterday. If they can't do it immediately, then they shouldn't be doing it at all, or until they can do it immediately. Access controls, it's pretty straightforward, but any questions?
I don't think I have any.
Okay. Lori, you saw her. She's the one. Reach out to her. If you CC me when you reach out to her if you want to. If she's not responding, she kind of hits and miss. She's doing the best she can, but her workload fluctuates sometimes to where, she gets to it when she can. So if she doesn't get to it, reach out to her. She's not ignoring you. She's just overwhelmed. Okie dokie. I'm telling you, this is going to be good. Oh, I didn't know it was going to do that. Let me go back. I thought it looked different, but yeah. I just wanted you to have that contact information. Cheryl graciously prepared these slides for the HAU, and she snuck that in on me and I didn't see it. Okay.
Actually, this came from one that Takia prepared, but I
Oh,
modified
okay.
it.
Well,
Been
I give
passed
you
around.
credit for it. Mhm. So that's access control. If we don't have any questions, once you get in there and you need, to reach out. But now we're going to move on to the tablet setup. And this,
Kara, I do have a question. I'm sorry.
no,
What do
don't be
the
sorry.
what do the clinics have access to? Are they able to log into this access control too, or is that just us?
No, they log in so they can print those reports.
Okay, so they can log in here too and see just their clinic.
Yeah.
And it will list their patients there with their patient ID, and then that's where they can print the report too.
Right.
Okay, got it.
And
And we set them up and they have to fill out the form and everything, just like we do to
Right.
get access to access control. Got it.
yeah, you'll email Lori and tell Lori the people at the clinic. It's usually the doctor and the office manager or the front staff, whoever's going to be handing them the tablet or need access to be able to run the report.
Okay.
Some clinics, they just want one and they share. You just kind of have to learn your clinic and see how they want to operate, whatever's easiest for them. But this is what they'll see. Okay. Too far. So we have the loaner tablets. And whenever we hand out a loaner tablet, we keep this documentation just for internal purposes. And we upload it to SharePoint in a folder in the facilitation resources that says tablet letter, I think is what it says. But you'll just enter the date and this information. And then there's a place for them to sign. I didn't capture that down there, but again, this is not, it's just so that if it's stolen, you can say, well, you've already given it to the clinic and it didn't get stolen in your possession. So we fill that out. And then as far as setting up the tablet, for the loaner ones, you set them up before you go to the clinic. But once they get their own and you have to go to the clinic and set them up, it's, these two links here, go to the search engine, enter the links in, and then.
Kara, I'm sorry, I got a question. I'm sorry.
No,
Is
go.
it just for Apple products or is it also for Android?
It's for
Like if they, okay,
we supply Apple, but for if, they can buy whatever they want to buy and we'll support whatever they want to buy. Have those links, it'll pop up, add it to the home screen, and then do it for, both of them. I mean, are you guys familiar with this? I feel like it's remedial for you, and I don't want to elaborate if I don't need to. This is what we share with our team, so I just want you to see what kind of information they've been given. In some cases, the bandwidth in the clinics, it times out and it can't completely do the entire download. We've seen this rarely, but it's happened. And so if that happens, you might have to take the tablet with you and take it home and set it up where you have good Wi-Fi or, wherever you can find good Wi-Fi. But it pops up a bad URL because it doesn't have time to download. Does that make sense?
yeah.
Okay. That's all I got for tablet setup. Now we're moving on to the EPR. In the EPR, the red cap, before I click on the link, this is just what it looks like whenever you set up. Let's see if it'll let me in there. Do you see red cap or do I need to do new share? I forget.
Just see your presentation.
Okay, thank you. You think I'd be better at this by now? I'm getting there. How about now?
Yes. We'll see right now.
Let me move you guys over so I can see it. So here's what looked like this, but this is the one where we do all of our EPR entering. You're going to add a new record. And then this is that screen that you saw. Remember last week we went into the OKPCP database. So you'd go there first to look and see if your clinic's in there, and that's where you're going to get the practice name and number. So by clicking on here, this is how you get them entered in. So once they're entered in, then you'll be able to enter in your documentation. So you've entered in practice name, ID, hit complete, and then save. When you get to one of these, if you want to Zoom me and if something doesn't make sense or clear, call me. I know it's a lot. Practice profile, this is where we keep a lot of the demographic information. You'll fill this out. Complete, save. It's a one-time thing. I mean, if the lead clinician leaves, then you'll want to come back and update it, but it's an electronic place to keep this type of information. Enrollment status. Did I hit save on that? Whoops. Every time you click on these, like whatever you pre-filled on the other one, it'll be pre-filled here. So it'll say, you know, whatever the practice name is. This information will be there too. Click SBIRT. This is where you do your recruitment documentation, contacted. Then if you've completed your recruitment, change it to complete. If you've reached out to them, they don't want to practice or participate. Enrollment start date, enrollment end date. This is where you keep track of enrollment information. Kickoff is the AD visit. So you go and request it from Missy. Now you've got it scheduled. It's over, it's done. They withdraw, and then whenever their end of study starts, end of study ends, and then whatever notes you need to put here, this is just for you. I mean, keep track of whatever it is you need to make a note for yourself.
Hey, Kara, this is Jimmy. I got a quick question. On the consent forms, it says it's a 24-month study. So is that still in play for the new clinics that we recruit?
We had this conversation, yeah. It's 24 months or as needed. I think is how it's worded. I can't remember how Jill said
Okay.
it. But
Okay.
yeah, I don't want to give them the thought that, you know, it's going to be over with in October. There's still going to be screening. It's just we're working on that. But no, 24 months or as needed. You know, less, like right now we have clinics that are dropping off because they've said we've been in this long enough, we're done. Okay. I'm not going to save that this time. Cancel. The practice technology is where you can keep track of what kind of EMR they have. A lot of times we don't know all of this information, but whatever information you do know, you can put it in there. You don't need to worry about my health status. The priorities and goals form, that's what you go over at the academic detailing visit. You just fill that out. A lot of these were blank. It's just the ones they actually want to work on. I clicked on the palm, I'm sorry, but you'd click on this one. So all of that is what you would do kind of before you really start intervention workflow. And then once you are ready to go, this is what the encounter form is, what we call it. EPR, encounter form. So whenever you're doing recruitment, enrollment, anytime you touch base, I wouldn't do anything that, I mean, you don't have access right now, but like starting last week, if you made contact with the clinic, then I'd kind of keep track of that and start last week with doing documentation. Have their date, what kind of visit it is, support type. For support type, see, we have recruitment, enrollment, we have your academic detailing, facilitation. Just trying to think. Once you're done with your screening workflow, this is a good one to click because we keep track of that. So we kind of know when they're going to start their screens. Administration is you're setting up a meeting. All you did was send them their weekly report. You didn't do any facilitation. It's just administration.
Kara, for us that are doing the data pools, is this something that we'll need to also put in our visits for the data pool? Or is this just practice facilitation?
This is practice
documentation?
facilitation. Let's just
Got
leave
it.
it at that.
Okay,
I'll
got it.
ask, but I don't want to create more work if we don't need to.
I agree.
I'm pretty sure that with the facilitator is with you during that visit, they're picking the data. Which one is that? Technology support is when they were clicking. And you guys have been added, so you're here. This section is for academic detailer, or if a clinic needs help and one of these people call them or they reach out to them. I don't know that this happens. Oh, well, I guess this is what the facilitators are clicking to, if you go with them. Reset that. And then we have our goals. So once you're doing facilitation, we try to stay away from clicking other, but sometimes other is just what you have to click. But universal screening, brief intervention, pretty much the bulk of what you're always going to pick. If you click, let me click one, because after you click one, then we have other things to click on. If it's universal screening, which one of these did you really focus on? And then kind of where are you at? This is DMAIC. I don't know how you say it, but that's what all these are. Basically, you start off with the D, you move to the M, A and I kind of go, and then C's whenever they're pretty good at what they're doing. They don't really need a lot of these other things anymore. They're in the maintenance phase, that's what I was trying to say. Each one of these have different things here. Again, pick what you can. If it absolutely doesn't fit in, click other. You're just going to be typing it in there. A lot of times you're only going to have one goal. In the beginning, you might have more than one, but after you get them up and going, it's usually just the one. Here's where you're going to write your narrative. You know, met with the clinic, saw Janet, we talked this, and she's going to do this for me. You know, I'll click on one and show you what else one of the facilitators have written. Then, you know, if they're not real responsive, then you're going to be one of these. If you show up and they're not even there, then it's going to be that. And there's that. If you know when you're going back, we'll plug it in. If you don't, a lot of times you're not, because it's pretty flexible. Here you write what your goal is for the next time, just so if you forget, you can come back here and look and say, oh yeah, I needed to pick up some more consent forms, or, you know, a survey. Prep time. Here, this one's not always, it's usually 0, but you know, occasionally we might get 5 or 10 minutes. Total time, follow-up time, how long is it taking you to write this note? Usually this section is, you know, 5 minutes or less, but if there's a lot of work you need to do after that visit, then it could be more. And then you'll see if I have comments here. If I ever see something that looks off or I have a suggestion, I don't ever expect you to come back and read this. I'll just say, talked with Ally about this. She's gonna go this route. Because I don't want you to have to, there's no prompt for this, so. But I have to verify that I know that if there's an issue, then at least I've seen it. Complete? You're good. Questions?
Oh, yeah, this is Jimmy. So is this a link that we access? Is that how, and you'll just give us the link or?
Yeah,
This is all in red cap,
yeah.
Jimmy.
So how do I access Redcat? I'm sorry, I've never done this before and
No.
I'm just wondering, is it a website? Is it on SharePoint? How do I access
Website.
Redcat?
It's
Gotcha,
this right here.
gotcha. Okay,
And once you have
And the-
access to it, you'll get an email and then it'll have, I think it comes from Carol.
okay.
And
She'll send us the
you're good to
link.
go for this.
Oh, okay.
Yeah,
perfect.
I think once you get your email, she can get you set up, but
And then I have another question. This information that we enter on these visits, is it exportable? Like, can we export that information?
Yeah,
Can you show us how to do that? Because we like to also track it in our tracking software, and that would be great if it could be exported and just uploaded if possible.
you'll have access to all these things. And I mean, I would encourage you to go and look at other people's notes, kind of see what they're writing, see if I can find it. All of these clinics were clinics we reached out to. But this again is both Palm and Do No Harm. When they built this red cap, they combined them. Here's one. I don't think we can export here, but we have another system, and if there's no reason why you shouldn't have access to it, but if not, then I can do it for you. Let me just click on a random one here. Yeah, no, we can't export from here.
Kara, if I could, there is a report capability in here. You see reports over on the left.
Yeah,
And you can build a report to contain. And if you need, you probably, I'm sure you guys can do that, but if you need help or want to look at some that's already there, like the encounters by primary PEA, or it used to be called PEAs, PFs, you can build yourself a report, and those are exportable to Excel or to various other things.
Yeah,
The way it was originally built, this is one of the older parts of it. So some things have changed to improve it. But when you try to export to Excel, because of the way the record ID and the name are tied together, you'll wind up with a report with no name or a PCID on it. And it's very frustrating, but there's ways around that. You might be able to figure that out. But she's talking about SSRS2, which is our reporting system that a lot of stuff goes into. So
I was looking for, like, where'd it go? It moved on me. You can click on that one, but yeah, we can create your report for that. And see, like for this one, it shows all of the notes over here on the side.
and if you can use the live filters up there, it will export and print exactly what you filter to. If not, and you try to just organize the columns, it's going to print everything. So it's kind of it's clunky, but I play with it a lot. So if you want to contact me or Carol, feel free to.
but it will export to like Excel. Is
Yes,
that right? Gotcha. That's
but you're going to run into some interesting things there. So have fun or let me know.
So are you saying we will have access to do that, or we have to contact you guys to get us that?
No, you can
report?
build reports, and people do,
Got
which
it.
makes it kind of confusing. Usually if I have one I'm working on and it's not maybe doing what they want it to, I'll call it a draft or people sometimes put their names beside them. But what I do is organize them like you see on the left there, so that you have things with certain themes. Like
They're already done like that, because I'm in it right
Yeah.
now. And see all of the same
already
reports.
organized.
They're
Yeah.
complete and organized just like that.
Yeah.
You can-
But there's where you can create them, copy that. You could, if there's one almost like you want, of course, you can copy it and then rename it and change what you need to and it's just the logic is not real sophisticated to try to choose what you want, but you guys that's what you do. So you'll be able to figure it out, I think. So.
Thanks, Cheryl.
You're welcome.
Okay, what else? I know it's a lot until you can get in there and really click on buttons. Might not have questions yet. Let me see. Create new report. I was just going to show you real quick what it looked like. And this is what you can click what field you want to pull over. Well, is it this one? So here's where you would go and find the encounter. Or whatever you wanted to pull over. Counter date, maybe. Add it on there. Then go down to you can do these things. Save your report. When you hit save, I think that's when it asks. That's how you want to export it. I've done this maybe 3 times. Let me go back. I have, Cheryl says, you kind of name them how you want them. I think it's this one. No. But anyways, on my reports, I have one that has bad reports because I didn't like them. So then I had to go back and I just filed them in a bad report because I didn't know how to remove them off there. Anyway, side note, I digress. Let me stop my share for a second. Okay, any questions about any of that?
And you can't, there is a capability to delete reports, but you might be careful not to delete someone else's that they use a lot.
Right, yeah. Okay, so that went a lot quicker than I thought, but we went over access control, the tablet setup, and then the EPR. And then this was the last thing I wanted to go over. Do you want a little break or do you want to go forward?
I'm good with going forward.
Okay, I say let's just go for it.
Okay. This is the big presentation from the Department of Mental Health. Ryan Fowler is kind of their suicide prevention resource. He used to be on SBIRT like fully, but now he's kind of moved over to that division of the Department of Mental Health. I do not intend to read any of this. I'm just going to go over it, familiarize you with it. Again, this is intended for you to share with your practice electronically. But if there's certain sections of this, or that the clinic needs extra help with, you can come here. You can go to the book that Dr. Duffy had developed. It's just another resource. But they want us to document that we're sharing this with the clinics. So even if it's just a section of, maybe you just want to go over the, familiarize them with what SBIRT is. You can show them these slides right here. It'll let me click forward. Some visuals. This shows that the green, they don't really need a whole lot, then the brief, and then the red. Why? Some questions here. Importance of screening. They give a lot of facts, like the 88,000 deaths. all of this section's on alcohol. So say, the clinic, this is what they want to work on. So this would be a section of this presentation that you could share with them if you needed a resource. Drug use section. That's one section. Symptoms. Suicidality. Is this okay going this route, or do you really want me to be more detailed?
No, you're doing good.
Okay, I mean, I know you have this, so I know you,
Yeah, and I kind of looked
Got it,
over
but-
it and it's very long. I don't think this would be something we'd want to show the whole thing to our clinics, but you're right, picking out things that are important, meaningful to the clinics. But yeah, this is excellent information. And I wondered, was this done back in 2017 or when was this?
I don't remember the day. It's been
Okay.
a while, but it's been updated.
Oh, gotcha.
I'm, that might just be the 2017 is the most current data that they have to put in here, but I think we did this I know we did for AOK late last year. And so it's been a little bit tweaked since then. Okay. Data related to Oklahoma. The screening tools that we're using for what we're screening for. Oops, go back. Workflow. It's just, we're going to help them with that. Transition slide. We're gonna, workflow is it's gonna be clinic specific. We have ideas, but not one size fits all when it comes to workflow. Here's an idea of how we feel it should flow.
So I'm joining here a little bit late. That shape
Yeah.
slide back there shouldn't have been in this.
Yeah, I know, I
It was
missed that.
actually for a different project.
Yeah. If we didn't have diabetes there.
Now, we do still use the audit and the DAS tool. And so some of the motivational interviewing things are still important, but those were slides that should have been modified.
Yeah, I missed that one. And I can remove it. Pre-screen for PHQ. And Chuck, we're just going through this. I've sent this to them previously, so they'd have, but I wanted to familiarize them with just seeing the screens. The audit.
So understand this slide deck that's here. This is something that the Department of Health expects us to present to every new practice so that they understand what SBIRT is and how it all fits together. It's not just, for us to show that to you because you guys know a lot of these things already. But what they're wanting us to do is as we go into a practice that we walk them through this slide deck because they have one that's a bit longer than this. And so what we've tried to do is to narrow down for the HAU project, narrow down some of the slides maybe didn't really add value. So this is just for to be able to introduce people to what SBIRT is and to take them through it.
We talked about that and how
Good.
they might just be able to get the first bit in one visit and then focus on the different screening tools. So,
Right, that happens.
yeah. But thank you for that.
And I went through this with for the SBIRT HAU, and we tried to kind of weed out because some of this is in the enrollment material, it's in here, it's in the recruitment material, and make sure we're not saying the same thing too many times, although sometimes it's good to repeat yourself, but
Right.
Audit visual. We have handouts that reflect this information too.
I think this graphic actually shows up on the long report out of SBIRT. when it comes out. I think it's either this one or something very similar to this that the clinician can then share with the patient and show them why maybe their DAS score was what, or their audit score was what it was.
I have a question about that, Chuck, since you brought it up. There's the long report and the short report.
Mhm.
So, and I know that they can both be printed and scanned into the chart. So what I'm seeing when I go into the charts is I'm seeing all different. I say all different. Some of them will do the short report, which just shows the scores, but some of them will do this long report, which actually goes through what they answered on
Right.
each of the questions. So what is the best practice? Do we want the short report or do we want the long report scanned into the chart?
I don't know that there's a best practice that we've given them. It's up to the clinic. It's what do they want to put into their patient chart. We make the information available to them.
Okay.
Their call as to what they put in there.
Okay.
Get something in. We want to manage
Yeah.
it too. If it was me, I would put the long report in.
Yeah. And I'll
What
tell
were the
you,
answers?
the long report is great for like us that's doing those chart audits. But now that we have access to access control, we can see that question 9, what that answer is. So I think maybe I would teach my clinics to do the long form and to scan that one in, just for that reason, because it's one less step that the chart auditors have to do, I guess, to access another system to get that question number 9. Also, I have a question on this long form. It doesn't have the tobacco screening on it on the long form. It has all the others, SBIRT audit, PHQ-9, but it doesn't have the tobacco. And I was just wondering why that's not on there. It's on the short form, but not the long form.
So I think that the part of the reason of that is that tobacco is not part of SBIRT. It's not an official part of the SBIRT program. And that's probably why they haven't carried that forward. We can ask Lori, as they're building out this new one, are they going to include it in the long report there? But just have to ask them.
Oh, I didn't realize the tobacco wasn't a part of SBIRT because it's something that we're tracking. So is
Yeah.
it something we shouldn't focus on then, their tobacco screening and interventions then, if it's not
We've
part?
brought it forward ever since the H2O days. And so when they were going through SBIRT, we felt like that was a missing component. So actually, since you bring it up, I'm curious why it's not on the long form. Seems to me it should be.
No, I agree. I'll email Lori and ask her. I'll take care of that. And Chuck's right about, the okay part of SBIRT is adding tobacco and depression.
Exactly. I mean, the original SBIRT, as I understand, was just after mainly alcohol. That was the big focus of that program. And then it was expanded to then include, any illicit drugs. They went down that path. And then as we came in, they were very concerned about depression. So then we said, let's add that one. And that's where it became SBIRT okay. That's why it's different than any other, if you will, there is a standard SBIRT. So that's why we have our own screening tool that the Department of Mental Health has built, is that the screening tools that other people have don't screen for all the things that we're looking for. I don't know if that helps you guys have a little bit of history and understanding, but now they've come out with the new version of the screening tool, which I think is, again, just leaps and bounds better than the old one for how it will work. So we'll see where that goes, but let's find, I'm sure Kara can find out why we're not doing tobacco and why it's not on the report.
Yeah, that's helpful to have that background, Chuck. So I appreciate that.
Yeah, and remember what drove all this was SAMHSA's relationship around this GIPRA survey. And I don't know if you've had a chance to go through and actually look it up and see one of them, but it's a beast.
Right.
Through, and Gifford didn't ask about those kind of things. So anyway, that's a good question to follow up with Lori and to key on.
We move along?
Sure, looks good.
Oh, no, won't move.
Mhm.
Here we go, Dad. What that looks like. PHQ-9. These are all the questions, you know how it rolls out different on the screen. They screen positive, Columbia for depression.
Yeah, so this Columbia, does it show up on the tablet for them?
No,
No.
Okay,
this
gotcha.
is something a
It's
workflow.
done.
It could be a paper form or just a inquisition from the provider. Gotcha. I didn't know if it showed up on the tablet or not. Gotcha.
Yeah, I think the plan has always been, and in the new document that Dan's put together, it is just using the paper form.
Or like you said, the provider asks the questions and documents in the EMR.
Yep.
Okay. So brief interventions. Like Cheryl was saying, you know, the document that Dr. Duffy gave, a lot of this is similar. Kind of give you some encouragement here. Prepping your clinic for a brief intervention. Well, in a clinic, I should say.
My understanding around the billing questions, this is where billing becomes relevant. At the moment, there really isn't a code. We just had this discussion yesterday. I don't think that there are codes in place now for doing screening. They're wanting to build that now. That's where they're headed next. But where the funding is, and we're working on trying to get a summary document. We talked to you guys about that yesterday afternoon on the measures call at the end of it, is trying to come up with a summary of where the reimbursements when brief intervention happens.
Once we have that, obviously, everyone will be disseminated too. Oops. This is just kind of giving your clinic, you know, all of those, what a brief intervention entails.
And the key phrase here is motivational interviewing.
Right.
They really want, there are a few things that Takia has been influenced by in her life, and motivational interviewing is clearly one of them because it comes up all the time. And what she sometimes forgets is Dan Duffy teaches that class. I mean, and that's what the book is full of, is what the dialogue ought to be between the provider and the patient. And so we try to reinforce that, yes, we really do believe in motivational interviewing. And we've tried to really put it into practice, but that's something that they really want to see emphasized with the practices, and then take the course that's out there available for that. And, you know, that's something we'd really want to encourage every practice. If they're not familiar or it's not fresh with them, take the training session that they provided on motivational interviewing to kind of brush up.
And I haven't mentioned that, but it's called Incognito. And
Right.
that comes later after they're enrolled, and it's a facilitation resource for them.
Is it free for them?
The health department pays for them to do it. Yeah.
Okay.
They have so many licenses. I should say they purchased so many licenses. And so they,
Okay. And is it for staff and the providers, or just providers, or?
Both.
yeah, anyone
Gotcha.
who wants to. Yeah.
And
Gotcha.
Incognito's got a wide curriculum of things, and you probably want to look through it and see which ones are most relevant to your practices. And if they're wanting to get training, but they don't have access, then we let Takia know and she takes care of finding more. Because other departments have access to Cognito. And if I haven't, it's been a while since I've been through any of those, but I think they use not real people. I think they're kind of using simulated situations, if I remember right, Kara. Is that how that's done?
Yeah. And then you click on what you think should happen next.
Are there CMEs or CEUs for this? Do you know? Sometimes that's a big motivator to get them do the motivational interviewing if there's
Yeah, I feel like
CEUs
there is,
and
but
it's
I can't
free.
remember.
Okay.
I'll check
Cognito. Okay.
incognito, and I'm gonna get you all set up so you can go in and get in there and look at it. So you'll be familiar with it before you.
Perfect. Yeah, I'm familiar. It'd be great to have a refresher to see if there's any new concepts since the last time I did it. So
Sure. And I should be doing it too. It's been a couple of years, so. You can click on that. That's a video. I don't know if you knew that with the other one, because I didn't mention that, but we had a good one. They give you an example of a good motivational interviewing or a good brief intervention, and then a bad situation intervention. And these are the things that happened during that call or that visit. More guidance on brief intervention. So this whole section would be, you know, how we talked about, they might just want information on why we should be doing alcohol screens. And so you could show them that section. This whole section is the motivational interviewing, brief intervention section. More on what it is, how it works.
And hopefully they should be going, yeah, I had that in college. Yeah, I had that in med
yeah.
school. But it's
Yeah.
time to go back and re-examine it and maybe make sure that it's fresh, because you know, a lot of people today are, you know, it's hard for people just to accept, well, I'm going to do it because the doctor said so. It isn't that clean, and people feel like that I mean, look at what we do today around the vaccination. Oh, well, my opinion is just as valid as yours. No, never mind that you've spent 30 years studying these things. So sometimes the motivational interviewing techniques can get past that.
Here's the 5 principles, and the next slides go through each one of these. The definition. These are things they learned in their class. Okay. So, you know, a lot on preparing them, let them know how the visit could go in the right ways that it should, and some examples of things that can be improved on.
You guys are going to see in the, I've got to do one more update on Dan's procedure book. It is chock full of examples of really targeting the clinician, how to handle this conversation. And for younger clinicians, for nurse practitioners, the mid-levels that really maybe didn't get enough of this in med school, that resource ought to just be invaluable to them of how do I handle some of these difficult situations.
And I sent you all that, the most recent document prior to
Yeah.
its training. Okay. Just wanted to
Yeah.
make sure that's.
But are there going to be updates to it, Chuck? Is that what you
Oh
said?
yeah, I've got
Okay.
another set I've got to put in there. I'm going to put the new screens in, some of the new screenshots that they gave us. The substance is not changing, but a few of the graphics that are in there are, so it's just too valuable to not keep up to date. And so that's what Dan's been helping me with. And now Takia's getting some new new material. We really had to work through an issue yesterday that she keeps wanting to, I mean, she's very focused about how she would use it. And it was, they were introducing ideas of going into access control to launch the screening tool. That is not the way we would use it in a practice. And it took me a while to figure out that that's where our disconnect is that the patients will never see access control. They will just see a tablet with a link to the screening tool, either in English or in Spanish. And when we finally got that through, that'll tell me then how we have to modify this procedure book. The access control is for the people in the practice that are doing things, setting things up, getting reports, looking for that PHQ-9 flag. But for the patient, they're just going to see what's on the tablet. We don't want them in access control.
Yeah, I agree. I agree.
Or terminology.
And what's confusing with this, ORS was the name of their screening tool for the longest time.
Mhm.
I didn't notice that until I saw this slide deck when she sent it over, and I thought, well, I wonder if there's a connection here, you know?
Yeah,
I think
they're
so.
two different things, right? There's the
I think
ORS
so,
training and then
but-
there's screening tool. Okay.
They rarely are referring to the screening tool as ORS anymore. That's kind of gone away, and I've even tried to take it out of the material that I've got and just let it show up as it is here.
Encouraging open-ended questions. Guidance on.
When I was at Utica Park, we took all of our facilitators that were there. These are the people going out and working as the care coordinator, actually. And we did exercises on this. We would throw to them a difficult patient that had a problem and challenge the care coordinator to come up with a way to do motivational interviewing, style questions, and do exactly what was here. I don't know that we've done that with our team. I think when we did the very early training with the Department of Mental Health, we got some of those topics way back then, but not recently. And that would be an interesting exercise to do at some point to be able to help communicate to even our team what this feels like, because it's not, for me, it's not comfortable. I'm much more directed. Then you need to quit drinking so much. That's easy. I'll probably change behavior.
Easier said than done. Let's see, reflections.
And I will tell you, Dan Duffy is a master at this. I've listened to him. I've watched him. He's fabulous around that.
Yeah, there's an art to it, Chuck. Definitely. So sometimes it comes natural to some people, and other people, you know, they really have to, because I'm kind of like you, quit drinking so much. But
Well,
yeah,
and I think with Dan, it was a learned behavior, and he really did learn it, but he practices it, because I officed right next door to him for 2-3 years, and he did this consistently in the things that we would work on together.
And I'm sure that he would be available to clinics if they wanted more discussion around it as well. Brief intervention, this section, all on suicide. Training them on how to do a good intervention.
So all of this is in the book.
Yeah, so it's,
Each one of these pieces is in there.
yeah.
yeah, and we're not seeing the in-depth brief interventions like motivational interviewing, those types of things. What we're just seeing mostly is, you know, they might talk about medication therapy, and then they'll talk about possibly referrals, but nothing in depth like this. But I think
Well, you won't see the motivational interviewing in the chart, right? That's
right.
technique that they use to communicate with the patient. Now, what you ought to see, if you're going to try to evaluate it, you'd have to see how many of them have been more successful. Have we been able to get more safety plans approved on? Have we been able to get more patients to actually over time reduce their bad behaviors? That would be the things that we'd want to get to. The deterra bag is a real good link to be able to tell them that if you think your patients could use some of these, we can get some for you. And then that gets them added into the harm reduction plan. And that one they don't have to enroll in. We just have to know about them. And that's where if they enroll in harm reduction, they have access to free naloxone, deterra bags, pill disposal bags, and that we've got a handful of gun locks, but those are going to be gone. And I don't think they're going to be restocking those. And they do have a handful of medicine lock boxes, but they're not going to have many of those. So mainly what we're going to have to give to them will be the naloxone. You guys been part of that communication process when Christy's been talking about it?
I haven't been.
Yeah, they have
No.
been included. Mhm.
So we probably need to, number one, include you in that. I'll bring that up to Christy. We need to bring you guys up to date. So we've got a separate program going with the Department of Health that we actually recommended to them. We knew that they were getting a lot of funding to be able to purchase Narcan, and they needed to get it out. And they've got what they call their naloxone hubs. And those are set up in different cities. It's on their website, I think, where you can go fill out a real small form and they'll just give you free naloxone. Or you can go to any pharmacy in the state and just tell the pharmacist, I would like a naloxone, but that one's not free. You're going to have, that will go through your insurance provider. You do not have to have a prescription, although I got one. I asked my clinician I want to see how the process worked, gave me a prescription. I gave it to my pharmacist. They filled it and charged me $50. So what the Department of Mental Health is trying to do is through their grant, be able to make it easier. So that's where the naloxone hubs come into play. We propose to them, how about if we connect them with the primary care practices that we have influence with, and then they added to it the deterra bags, the gun locks, and the medication lock boxes. But what it's going to mainly be will be naloxone. So what will happen is if a practice signs up, there is a real simple form that we've built in RedCap, and we'll connect you up with Christy Madden to be able to get the details on this. But once they sign up for it, Christy then will ship them one case that is 12 kits of naloxone. And there's some other information that goes with it. And once a practice, it's up to the clinician there to decide who it goes to. Now they need to understand that it's a $75 drug that they're getting. And we want the patient to have had some exposure to training on how to use it. And so there's a little slide deck that's there that you can use parts of, but they don't enroll. We don't do any surveys with them. This is just a service that we're offering back through the Department of Mental Health. Once the practice uses up those original 12 kits, and there's 2 naloxone units in each kit, once they use up the 12, then they will order a replacement directly from the Department of Mental Health. We aren't still in it, but right up front, you would have a role as the PF in taking kind of a generic workflow that we have for this and helping them implement it. Then there's a little process where you go back a week later to see, is it working? Have you guys given any of this out? And just kind of check back with them after that. But we think this is going to be something that the practices will be very excited to be part of, because it doesn't cost them a dime. And it's something where they can look at, where is the risk? What patients do I have that are elderly that maybe forget that they've already taken their hydrocodone, and then they double up or take way more than they meant to? That's happening. And then the naloxone will bring them back. So are you all familiar with that med? Have you seen
I
anything
am.
before?
Yeah, there definitely needs to be training on it. And I think that's great. Yeah, there's a lot of naloxone training programs out there. So I think this is great to be able to get to jump into and provide it to the clinics for their patients.
We'll be able to do this as long as the Department of Mental Health keeps getting funding for it. Now, we don't know how long that's going to be, but they've got a good amount of it right now. And Christy Madden's office right now is pretty much filled up with Narcan. So she's ready for it to leave her office, because when we told them, okay, we're ready, we're putting our process together, they kind of got the cart before the horse. They immediately shipped a ton of it over to Christy. We weren't ready for it yet, but we are now.
Is
Everything,
it the injectables or is it the nasal?
the nasal,
Gotcha.
it's incredible. I mean, someone can be completely unresponsive, not breathing, laying on the floor, you squirt it in their nose and it wakes them up.
Yeah, and sometimes they require that second dose, so that's good to know.
Does.
Yeah, yeah, and then to call the EMS too.
Each unit has 2 squirts in it, as I understand. And then there are 2 of the nasal injectors in each kit. So, and we're leaving it up to the clinician to make up the criteria. It may be it's someone that's a patient who has teenage kids coming into their home. And that might be the justification for putting it there. I'll get you guys with Christy so that you can see her dog and pony show on that.
Yeah, and we just had that last
Perfect.
week. So this really is new. It's not new, but it's just now rolling out. So I don't know that we've even had any clinics, really sign up yet. So.
We got
Okay.
I've already heard from Christy. And
Good deal.
we think there's going to be a lot of them. And the thing is, I'm just saying, this is a great place that if you're going through this slide deck and they're falling asleep saying, hey, wait a minute, let me show you something that's really important here. And this would be the time to show it to them.
And that's what these next slides are resources that we have. The health department has. You can just get,
It's the Department of Mental Health, right? Not
Right.
Health Department.
I know, I always say that because I worked there before and I can't get that straight in my head. Sorry. Information here, text hello.
Yeah, and this is one of the things that I see the clinics and the providers asking for most is the resources to like refer. They says there's just nobody. There's not a lot of behavioral health or places to refer to. So that was what I was wanting to see is what resources we can give them. This is an app, I'm guessing.
Yeah.
This right here.
My3, it's an app. Get help now. And then this one's their suicide prevention hotline. And then this one, it's a text, the crisis text line.
There is some work that's being done now. Let me go out there. They are, oh, that's the other one. Oh. Okay, that's where I'm looking. So, are we set where I can share my screen real quick?
Sure. Can you? Do I need to?
Yeah, it's coming.
Okay.
So if you guys have not, I would imagine you've been out here already, but what they're really asking people to do is to start using their website. They've done a complete rebuild at the Department of Mental Health about their site. And right up here at the very top is what they're trying to get across is that there are these services within reach that they're talking about, but they built services directory, and you all might want to take some time. I know that at different points, Takia has walked us through some of this, just showing us where the services are, and they've been putting a lot of time and money across their agency to address exactly what you talked about, Jimmy, because so many of the rural areas, they just don't feel like there's anybody out there that they can contact, and there's still going to be gaps, but they're doing their best, although the website's a little bit slow. They are really trying to add more and more resources for people, and that is to come back and identify what resource they're looking for, what they're in. It'll give you what are the categories of things that someone might be looking for help on, how you can get to there's your naloxone hubs, how to find a practitioner, how to do drug disposal. That take you over to the Terra bags. But the big one that I think that they're waiting to see happen is this new national phone number. Are you guys following that?
I haven't been.
Yeah, so it's not 911,
The
but it's,
211?
I think, no, I don't think it's 211.
Okay.
211 connects us to a local provider. I should know what it is. And we just heard a presentation from them not too long ago. Let me look through this real quick. See if it pops up here. It seems like it's like 411. Okay, I would be flunked right now because Takia would not be happy that I don't remember it.
There's the 211, but
Yeah, I thought it was 211 too, but
Chuck, scroll up just a little bit. I think I saw something. I think it was the. So
Well,
like,
there's got to be billboards and everything else all over the state on it. And I'm really surprised it's not right here on their homepage. So what they're doing is they're actually, and this was in the newspaper from the agency head just recently, that they're putting in place mobile units that are crisis units, where if you have an issue, you call the crisis unit and they're able to give immediate help right there. But if it's more important than that, they dispatch a crisis unit to you. And we need to have Takia really talk about that, probably with our whole team, because I don't know that we're, the timing on that is this summer, is what I've been hearing. And I think we just really need to be ready to roll this out with them. All right, let me take that on and I'll get that information from Takia, because I know that that's where they're wanting us to go, is to be able to make that available to address the very problem that you're talking about. And they're talking about mobile units statewide.
yeah, this is great, Chuck. I've already got the website pulled up and favorited it. So I'm gonna be kind of going through it today to see what's on there.
Well, they've got things here. They've really been focusing suicide, but I think it's more than that. And I think you'll wind up finding that when you get in here. And this is the kind of stuff that we really need to kind of refresh all of our teams about, because a lot of this is new, and it's where they're putting a lot of their emphasis, a lot of their resources today. So I'm making a note.
I can put it on one of our agendas. We can go through it.
You know, when we do when we kind of do the refresher, we need to do that one.
Yeah.
Okay. All right. Sorry to interrupt, but that one, when you made that comment, that really jumps out at me about what we got to do.
You gonna stop your share?
I will do that right now.
Thank you. Let's see where I'm at now. Oh, here. So all of those previous slides were for brief intervention. These next coming slides is a section on referral to treatment. And again, this would just be a section you can share with them. Here's some
All right,
resources.
so this page shouldn't be in here either. This is
Okay.
actually part of the HAU slide deck that's for them. And these are the resources that we're providing through the HAU practices where they built relationships with Morton and these other facilities here. And that's all part of this United Healthcare United program. But the truth is you need to figure out with each practice, how do they do referral management? And that would be something that would replace what this is. So we'll want to be sure and pull this out before we give them the slide deck to be able to share with their practices.
And I'll send you an updated. But you have information for now for your referral. Okay.
And I don't know what's wrong with that slide.
Yeah,
But we need to rebuild it because that's a bad looking slide. It was taken with a fuzzy camera.
Mm-hmm.
Gerald, how did that happen? Was that something they gave us?
I don't think it was like that before. I don't know, but I thought my glasses were going bad on me. My eyes are going.
I did too. I looked and I was like, why can't I see this very well?
I was bobbing my head up and down trying to get my bifocals to work.
So their Oklahoma Network of Care, can we click on that and see where it takes us? Because these are the places they're telling us they want us to send people. And to
That was that website you just showed us, Network of Care, wasn't it?
There's the
Is that where it
Oh, yeah.
goes? Okay. Okay, I'm Ready is one of their programs. SAMHSA, we know because we work with them. 211, you guys know about their resources. Psychology Today, that directory, they say is the most complete list of how to find therapists, psychologists, support groups in the state and around. So they have recommended that, and we have tied that in to our SBIRT AOK.
I don't know what happened here. Sorry.
You jump out. Is that the end of the slides?
Well, it went to the end, but let me go over here.
Okay.
Let's see. No, that was the last slide.
Okay. So we need to rebuild that one slide. I wouldn't want to put that in front of
Funny.
some of the practices.
I was trying to click on that Psychology Today so you can see it.
'Cause I was on a call where we actually used that. And I think Dan was actually looking for something. He wanted to see what it was giving us. And he felt like that it was a very valuable resource.
Oh, it actually worked. Let's see.
We're not seeing anything, just so you know.
I know. How about now?
There you go. Give us a zip code that's going to be tough, or a city. Jimmy, give
73801.
74801.
3801. That's Woodward.
All right, let's see what Woodward's got for us here.
Nothing. Yeah, usually. That's about right.
That's not good. Give us a zip code. See, we can tell them, guys, this doesn't work.
Oh. As I say, it only shows it's wide. It was within 30 miles of Woodward, so it would have just had to have been Woodward probably included in that.
I'm sending my grandson to Woodward. but it's not Woodward, Oklahoma.
Ah.
Where is there another Woodward, Chuck?
Pennsylvania, and it's an ultimate BMX camp, and he has been dying to go, and that was what Christmas. Doesn't Guyman have a Y in there somewhere?
Why, I don't know how to spell it. I thought it was like that, but that don't look right. Allie, you know how it's spelled.
No D on the end.
Skyman. Okay.
Yeah, I don't like that either.
Yeah, there's never usually anything in Diamond. Usually they have to go to Amarillo. It's the closest of things for them.
Holly, I
This
have-
is where they need the mobile units accessing
Exactly.
these
And-
areas. Yeah.
Notice there, you could widen it out to 20 miles or more, but you're absolutely right. And so the interview that was in Tulsa World recently was the commissioner who was saying, there are too many dead spots, no pun intended, too many places where there's no help, nobody's there, and there are crises. And they've got these crisis units. Now, I don't know how it's going to work, but there are these crisis units that they're going to be putting out there where someone's there on the phone to be able to answer, to take the call, and then to be able to actually go and help physically intervene when necessary. And there's like multiple steps that they go through that's to the point of transporting an individual to a facility where they can get help. So that's what we want Takia to talk to us about, is to explain, now that this has become, it's starting to take form, walk us through what it's going to look like. I've written it down here.
What else? Go ahead.
Terry Slanton Hodges is the agency director, and she first explained this to us a little over a year ago in a webinar that we did. She talked about the things she wanted to do, and it's now coming to fruition. So it'll be fun to get an update on that.
Yeah.
Kara, I don't know if this would be the time, and Chuck, you were in on the HAU meeting to, someone ran into a little glitch with the long form when you're doing the Spanish,
Mhm.
when they did the Spanish screen, that you might want to warn your practices about. Someone printed out the long form or started to print it out, and it prints it out in all Spanish first, and then it prints it out in all English. So they didn't see the English part and they just gave up. So luckily the patient had screen negative for everything, but you might mention that if you have them that are going to use the Spanish screen, that it will print in Spanish first and then English on the
My
long.
understanding is, Cheryl, you've been part of this, the short form is always in English.
Yes, it's in English. I mean,
Now that's in English.
on the
but
tablet, it's in
long
Spanish,
form,
but the
yeah.
short form report is in English. Yes.
Yeah, and the long form that they can pull off of access control, if it was done in Spanish, well, it looks like, well, it's just all Spanish. Well, I can't use this. But the idea was, and Cheryl said it right, we could get rid of the Spanish component and just let it show the English. But you may have a clinician working with the Spanish speaker that it would actually allow them to share that with that individual, to show it to them in a language that they can understand.
Yeah, because there are visuals on there, the bottles of alcohol, dosage and stuff like that. So it's good. But I told them also, it's like, I'm sure that person who did that, if they were not the person who was interpreting or helping with the Spanish speaking patient, when that started printing out, they didn't know what to do. I told them it was like when I changed my browser just for fun to Klingon one time, and then I couldn't figure out how to get out of it because I don't speak Klingon and get it back to English. So, you know.
You keep letting everybody know you're a Trekkie every time you do
I know.
that. Those people are going, Klingon, what nation is that? Are they part of Russia? Is that one of them next?
They're also working on more resources in Spanish too, just so you know.
Yeah.
I'll have resources to give them. But that's all I have for today. Do you guys feel equipped? Comfortable?
Yeah, I think this definitely gives us a start. And then, you know, we can always refer back to the slides or the recording and call you. If we
Yes,
need
call me.
help.
Yeah,
So I checked this morning with Lee Cassie. I actually sent her a note yesterday and said, talk to me about what's happening here, what's going on. And she said that the procedure that we have now with affiliates, that is going to get an OUHSC email, goes over to IT, and IT then submits the request for us. And now what's happening is that we're a certain kind of customer in which Lee sends a request. IT then assigns the request to one of, and I don't know who IPS is. I don't know if that's the name of a department or what, but they then have tier 1 people, and tier 1 then contacts Lee and wants all the information that you guys have provided. So it just sounds to me like we've let bureaucracy take us over. We've already been contacted by tier 1. They have all the requested information.